I think that looks a bit more like work, isn't it? Isn't it a beautiful library?
Yeah, that's
Wow.
right.
Is this the Hogwarts library, or do you know Harry
Yes, I can
Potter?
tell you.
Yeah. That's
No,
yeah,
it's
it looks
not.
like.
It looks like Dumbledore's office.
I need a beard for that. Come
No
on.
computer idea.
I'm way too young and I shouldn't have shaved for that.
We'll be expecting some witches coming from the back or something.
You mean you want my kids to join? No, not really.
Maybe after the session, we'll allow them.
Do you hear me now?
Very well, Jan.
Very well.
Yeah, but that's through the mobile phone. I try again via the computer. Do you hear me now? I guess yes.
Mm-hmm.
Yes, we can.
Let's try this.
One question, are we already online? It appears that participants are joining.
Yes, they are joining now.
So we are not in a protected kind of pre-meeting room.
No, because I did some manipulation because Jan had, problem to join in. So I did some trick to let him in.
So everyone is looking at us.
So, yes. So, Jan, are you trying from the computer?
So,
Can you see the name? I can't see the names of the attendees, right? It's just the
You
panel
can.
names.
Sorry.
I can see you. It's not showing up.
Isabel, can you approach a little bit the microphone from you? It seems the voice
Like
is a little
this?
bit...
Better?
Yeah, better.
Okay.
Very much better.
Ali, how's my voice? Is it from the quality sufficient or do you need an external microphone?
I think it's okay from your side.
Okay, thank you.
Yeah. And now we need Jan.
Where do you see the names of the attendees? I'm sorry, I can't. I just see attendees and numbers.
Yes, you can't see the names.
You can. You just have to. There's discussion and participants, and then there's Zuschauer or participants, so you can see the list.
I see participants and and I
Let me
see
see.
also. And if I click on attendees, I don't see the names. There's just the number showing up.
Yeah, on the participants list, you have attendees, and then you have them. I can see the names.
I
From
can't.
your side, you can't.
No.
If you click on attendees, you have.
Yeah, I did.
And Matthias, you can. There's something with your account, Isabel. I don't know what. And Joe.
I can see the names of the attendees.
All right.
Okay. Too bad.
I even see Jan 4 times.
Jan is there 4 times.
Yeah, correct.
Oh yeah.
Looks like a split personality.
I think he's logged in several times here, and So Jan, could you succeed in entering from the computer?
Well, I've only the slides, but I don't see you, and neither the computer, neither the camera is working.
Okay, I can see you here. You logged in several times in.
Yeah.
And if you activate your camera from the computer, maybe?
Doesn't work. There's no button.
There is no button to activate.
There's no button to activate.
I think we shall go like this, Jan, because the image is there. We can the participants will see you, and I can give the control to each of the speakers, and then you can still go on moderating. We can hear you, the others. What do you think?
Yeah, I think we better start. Huh?
Yeah. So
once again, I do not agree that you will use Zoom for further meetings. This is a crap medium, in my view. But you know my medium.
I have already transferred your thoughts about it. So we give the hand now to Isabel. Isabel, you have the control now. So when we start, Jan will do the introduction, and then we'll start.
How can I cannot again.
It's only by click, by these ones.
Okay, good. But I go back, right?
Yeah.
Yeah.
Are we on now?
Yes, we can start.
Okay. So good evening, or I hope it's evening and not night for the most of you. So welcome to this
Jan?
for thoracic cancer patients in the era of COVID-19, which is striking epidemically and probably is hitting most of your countries at the moment. So we thought that three topics were of utmost interest: is how to handle the staging and how to handle the patients who goes to surgery. The second is how to handle patients who go to radical or palliative radiotherapy. And finally, what to do with patients treated with systemic therapy, either chemotherapy or immunotherapy. So we have three speakers tonight coming from different countries. And the first speaker I'm very pleased to introduce is Professor Isabel Opitz, who is the director of the Department of Thoracic Surgery at the Zurich University Hospital, and he's also the liaison between the European Society of Thoracic Surgeons and the Assembly 11 of the ERS. So it's my great pleasure that I turn now over the microphone to her. So we will have the three presentations on the row. You can forward your questions via the questions and answer box, and then at the end we will address them in plenary. Should you have any questions or any remarks on the quality of the transmission, please use the chat box. So don't use the chat box for questions, and don't use the questions and answers for chatting. So having said that, Isabel, the floor is yours. Thank you.
Thank you, Jan, for this kind introduction, and to ERS especially for this kind invitation. I'm Isabel Opitz, a thoracic surgeon from Zurich, and I will talk about the cancer treatment, lung cancer treatment, and in particular here for surgical patients. I have no conflict of interest to declare. I will talk, first of all, about the potential risk that is eventually higher in lung cancer patients, if and how COVID-19 testing should be performed in lung cancer patients, and then spend most of the time of how to do a triage of lung cancer patients for surgery, and talk a bit about the surgical approach for lung cancer patients. First of all, I would like to share this facts and figures here from a Lancet Oncology publication, which shows in particular this notable decrease in cancer diagnosis in the Netherlands. It has been shown that this decrease is remarkably when compared with the period before COVID-19 outbreak. This was most announced or pronounced for skin cancers, as you can see here in the red line of the figure, but also across all other cancer sites. And this was holding true for all age groups and all geographical regions. And this is particular scaring facts and figures for us as oncology doctors. So one reason for this is surely that our hospitals were forced to progressively reduce the services to preserve their human resources for COVID-19 patients. And furthermore, patients and also most probably the referring doctors were scared to send the cancer patients who potentially might be more at risk than the general population. And this has been shown in a few publications that are out now since the outbreak. Here on the screen, you can see a publication from a Chinese group analyzing 2007 COVID-19 cases from over 500 hospitals and 31 provincial regions in China. And they could show in this patient population that the risk in patients, it was 18 cases with a history of cancer to die, was higher. Obviously, these are still very limited data, not only because the patient group without cancer is much higher compared to the ones with cancer, and the cancer patients being older, with a mean age of 63 in this population and 48 in the non-cancer patient group, but still it is seems to be a higher risk. However, this higher risk has to be outweighed with the fact that a failure to perform a cancer surgery or indicated cancer treatment in timely fashion might eventually have a higher impact on patients' survivorship, and therefore the major risk for patients with cancer is most probably the inability to receive necessary medical services, which I will come to in a later slide. So why are or what do we have further numbers from all these publications that are out so far? The case fatality rate, meaning the number of deaths in positively tested patients, is increased by the factor 5.6 in patients with cancer. It was also shown that there is a significantly higher rate of intubations in cancer patients, in particular in the age group 66 to 80 years. And there was also a higher risk of complications if surgery or chemotherapy for cancer were performed within the months preceding the COVID-19 diagnosis. In this previous publication from the Chinese group, there were 4 lung cancer patients out of 18 who have received chemotherapy or surgery within the months before. What might be the reason for this cumulative or for this higher risk in lung cancer patients? So first of all, there seems to be a susceptibility to COVID-19 in active and former smokers due to an active expression of AC2. And then tobacco-related lung damage has also been shown to predispose to COVID-19 complications. Immunosuppressive effect of prior chemotherapy in particular, and also of tobacco smoke, and the tumor itself may play a role. And last but not least, the defective pulmonary architecture, for example, in COPD patients or in the which are mostly associated to lung cancer, predispose to an infection. Macrophage infiltration also causes a higher risk for a cytokine release, which is known to happen in cancer patients, and this is known for a trigger to be a trigger for ARDS as a complication of COVID-19 infection. Last but not least, the patients are usually of older age and have, because of the shared risk factors, also cardiovascular comorbidities, which are equally known to be a risk factor for COVID-19 infection. One problem is also that lung cancer patients do show the same or similar clinical symptoms, being cough, fever, and shortness of breath, and might have been tested in particular diagnosed and assessed in the earlier phase because of this similarity in symptoms. And a significant proportion of lung cancer patients need steroids for prophylaxis treatments and symptom control related to their cancer or to their COPD comorbidity. And this is well established that steroids might reduce inflammation and immune cellular activity and is deleterious in the management then of COVID-19 ARDS. And these treatment might mask early symptoms, therefore, also of the COVID-19 infection. So coming to my next point after concluding this higher risk for lung cancer patients, the next step would be, do we test all lung cancer patients coming to our clinic? That a screening model would allow for an early detection and potentially reduce also then in a second way the risk of severe complication. It is announced on the ESMO homepage that they will soon publish proposals and treatment recommendations for the triage. It has been already published, and I will come to this on a later slide, but also for the lung cancer patient testing. So stay tuned here and for further information. In principle, the baseline testing should be recommended, to my opinion, in particular to perform later active treatment. If you have a patient with a ground glass opacity, but a negative swab test, a sampling bronchoscopy for higher sensitivity should be considered. I would like to share this initiative of a global collaboration with some early numbers of thoracic cancers with you. It's called TerraVault, and it's a Thoracic Cancer International COVID-19 collaboration involving 21 countries worldwide. And the aim of this collaboration is to capture patients with thoracic malignancies and COVID-19 infection, regardless of the therapies they received. And as of the status about a month ago, the first results I will show to you are based on the first 200 patients that are enrolled. They had a median age of 68 years and at least one comorbidity in more than 80%, which was primarily arterial hypertension and COPD in 1/4 of the cases. 80% of the patients had a smoking history, and most of the diagnoses were non-small cell lung cancer with a smaller proportion of small cell lung cancer patients, and the remaining patients were mesothelioma and thymoma patients. In more than 70%, the disease was already in a metastatic stage, and 74% of the patients were receiving active treatment, being either chemotherapy alone, immunotherapy alone, or TKIs alone. There are no patients with surgery included. The short-term outcome is that they had in 76% needed to be hospitalized, and really high mortality of 34.6%, and in most of the cases was associated to COVID-19 infection. because of the most common complications related to the disease being pneumonia and pneumonitis in nearly 80% of the cases, or ARDS in nearly 27% of the cases. The clinical presentation was, as I mentioned before, as is the particularly challenging situation is that COVID-19 and the lung cancer symptoms are quite similar. In the univariate analysis of these 200 patients, there was no association with a specific cancer treatment triggering for a higher mortality, which was equally the case in the multivariate analysis. So my next part of the presentation will be dedicated to the most difficult question for us, surgeons, radiotherapists, oncologists, and pulmonologists, is how do we triage our patients for whatever treatment? And the European Society of Thoracic Surgery has sent out a survey as of the 12th of April with a questionnaire addressing many points in for the crisis, but I would like to share the following question with you and ask the audience for their opinion to give a hypothetical prioritization for the following patients in the current crisis. You can read yourself, but the first case will be an 80-year-old patient with slowly growing, partly solid T1A and 0 peripheral lung nodule, a 65-year-old patient with normal pulmonary function and no comorbidities with a 3-centimeter right upper lobe cancer, 75-year-old patient with normal pulmonary function, performance status 1, central cancer candidate to right pneumonectomy, a 70-year-old patient with single station N2 disease and right upper lobe cancer, and the last case being a 55-year-old patient with normal pulmonary function tests and 1 disease in the right lower lobe. So I would like to ask you to give your vote on these patients, and maybe we can have a look at the results later in the discussion. And I can show you what was the result from the return of the European Society of Thoracic Surgery, showing a very ambiguous outcome here, that even the surgeons were not quite clear of whom to prioritize unless the 80-year-old patient with a slowly growing cancer, which could be postponed. So there are now from the, there was an initiative from the American College of Surgeons and Commission of Cancer to give some guidance in this difficult situation where there were progressive reduction of surgical volumes and elective surgeries. And in this article in the Journal of Thoracic and Cardiovascular Surgery, they tried to give for different scenarios recommendations and trying to consider the limited resources and capacities and also alternative treatments. They are obviously not to be considered as rigid guidelines and have to be adapted to the specific situation. What I really like about these recommendations is that they try to adapt those to different scenarios in a phase 1 being the situation that only a few COVID-19 patients are in the hospital, the resources are intact and there is no rapid escalations. And then they divided surgeries to be performed as soon as feasible, surgeries that can be postponed up to 3 months, and then a third category where alternative treatments should be considered. So in a phase 1, which needs to be considered as a nearly normal situation, also these are the indications that were recommended where surgery should be performed as soon as possible in a solid or predominant solid lung cancer, more than 2 centimeter, node negative, also in node positive cancer, post-induction surgery, and also staging should be performed at this stage. In a phase 2, where many COVID-19 patients are already in the hospital, the resources are limited and a rapid escalation is expected. the tumor-associated infections and tumor-associated hemorrhage and complications should be performed as soon as feasible, and elective procedures should be postponed in the most critical phase 3, where the hospital resources are exhausted. Surgeries to be performed as soon as possible are only the ones where we have threatened airways or tumor-associated sepsis or complications in unstable patients. The European Society of Medical Oncology has equally given out priorities, but more related to the actual procedures. I will not go through every single point. The differentiation between those two recommendation guidelines are not very much different, and they, as I said, have equally a high, medium, and low priority guidance in these documents. So for my last point, I would like to come how to perform surgery in this COVID-19 pandemia. And so if you perform bronchoscopy or EBUS, but I'm sure Joe will come to this point later, these are procedures equally like tracheostomy that are thought to be associated with a high potential to disseminate COVID-19, and they should be performed only in selective cases and ideally in patients that have been screened, and in a setting of strained resources and potential exposure of the staff in these staging procedures. As I mentioned before, a non-invasive staging evaluation is also reasonable. In terms of the surgery, the aerosol generating procedures should be performed with the precaution and special equipment with FFP2 masks, eye protection, gown, and gloves. And this is in particular for the cases when you have an intubation, and smoke evacuation and using electrosurgical devices should be used to minimize the exposure to the surgical smoke in these patients. And one recommendation that was equally be given by this network of the thoracic surgeons is that the most experienced surgeon available should perform the surgery to limit the exposure time in the OR. There are currently no recommendation in terms of the approach of surgery. There are recommendations for gastrointestinal procedures, for laparoscopy, to minimize during the pneumoperitoneum the aerolization, to use protective measures, but this is not available for thoracic surgery. My last slide shows the strategy that we chose in Zurich for our lung cancer patients. So currently all patients entering for surgery are tested for COVID-19. If positive, they are transferred to a different OR tract. Minimal invasive VATS or robotic assisted surgery is currently, as always, the preferred approach for the lower risk of aerolized COVID-19 exposure. And this is actually chosen for all our procedures, and minimal invasive is only approach is not taken when the OR time would be significantly longer. We use automated stapling devices whenever possible to minimize aerolization, and therefore also don't use the laser for our lung resections currently. And for the robotic procedures, using a CO2 application, protective measures may be considered. In terms of our postoperative 4 weeks follow-up controls after surgery and equally surveillance, we are currently using telemetric consultation. And with this, I would like to come to my conclusion, and I'm happy to hear your questions and discuss with you further aspects. But for now, I would like to conclude lung cancer patients should be a priority group for COVID-19 prevention. And there is a requirement to have an international consensus for testing these lung cancer patients as a population at risk. For the treatment triage, a shared decision-making is essential, and a treatment plan has to be developed by a multidisciplinary team, and afterwards discuss decisions also individually with the patients as in every situation. Suspending or delaying cancer treatment, and here for my talk, I would say for surgery, is only in severe pandemic scenario something that we can recommend. In principle, lung cancer surgery can be performed safely and should not be postponed in order not to decrease lung cancer prognosis. And with this, I would like to thank you for your attention and my team here in Zurich for standing together in this difficult team, and Raphael and Chloe who helped me supporting in preparing the slides here. Thank you very much.
Okay, thank you, Isabel. I have one quick question. Your multidisciplinary team meeting, do you do it by a webinar or just still face-to-face in the meeting room?
That's a very good question. So initially we did a Skype tumor board, but then we decided that only one representative per discipline can enter our discussion room because it's big enough to have the social distancing over 2 meters.
Yeah.
So we went back to face-to-face meeting, but with very limited participant numbers.
And how does that impact on the quality of the discussions?
No, actually not, because the participants that are present are normally the directors or the group leaders for the lung cancer center. So from all disciplines, there are senior staff members participating in the discussion.
Okay, thank you. So
Thank you, Jan.
we now turn to the second speaker of tonight or this evening, and it's my great pleasure to introduce Matthias Guckenberger, also from Switzerland, who will discuss consensus statement, which was very recently released by the Estro and the Astro regarding radiotherapy, lung cancer radiotherapy during the COVID-19 pandemic. And it's an effort for different famous and renowned radiation oncologists. So please, Matthias, go ahead.
Thank you very much, Jan. Thank you very much for ERS for the invitation and for organizing this webinar on very short notice. And also thanks very much, Isabel, for having an excellent introduction, which covered many important aspects for management of COVID-19 lung cancer patients. So I will have a bit more relaxed situation and being able to focus on radiation, where I have to admit we don't have so many data. What do I mean? We don't have actually data that patients who are exposed to thoracic radiation are at an increased risk for a more severe infection of COVID-19. But because we don't have any data, that doesn't mean that we should be less cautious. We still have to make very balanced decisions. And we decided between the European and American Societies for Radiation Oncology very early on that the recommendations we give and potentially to depart from guideline recommended practice that should follow the same quality requirements as we would do it in normal times. So it should be a large group of people having experience in guideline processes, in developing recommendations. And that's what we kind of tried also to do in this pandemic situation. And I will present you the results in the next couple of minutes. I don't have any conflicts of interest. The introduction or the overview, I will give a very quick introduction, the methodology behind this practice recommendation, and I will specifically focus mostly on 6 lung cancer cases, which will be typical for patients you will see in your day-to-day clinical practice. And we try to come down to hand down recommendations which you can use in your day-to-day clinical practice. We also differentiated between 2 pandemic scenarios and then also come to some conclusions and summaries. So the background, I think, has been mentioned before. We are facing a pandemic here since March 11th. We are aware of risk factors very broadly, aging comorbidities, and we do have some data, despite this data is not very strong, I would say, that cancer patients in general might be at an increased risk for severe COVID-19 infections. We've discussed it just recently within our cancer center. I have not seen a single COVID-19 positive patient in our radiation oncology department. And the same is also true for our medical oncology department. So we cannot reproduce these numbers, luckily maybe, that these patients do have a severely increased risk, at least in the medical oncology and radiation oncology environment. What we have to take what we have to be aware of, that we are facing two challenges. The one is the infection itself. So the patient might be at an increased risk, but the challenges from the pandemic, they are on a different level and they have to approach differently. And we should differentiate, as we have always done in pandemic situations, between different states of the pandemic. There's the early pandemic phase, which is called contingency of standard care, where the aim from a population perspective is to suppress the spread of the coronavirus. And only in a later phase, where we're seeing severe damage to our healthcare system, there we might have to prioritize treatment of our patients. And that needs to be differentiated. Luckily enough, there's not been many centers which have entered the second phase, the crisis of standard care. If we face the challenges, again in this early phase where most of our centers are currently in, we see risks and challenges for different populations. The first is for healthcare co-workers, and that might be in particular relevant for radiation oncology, where our patients have to come, if they are not treated with stereotactic radiation, then they have to come for 20, 30 times repetitively to our department, and there might be an increased risk for healthcare co-workers to get infected by this repetitive exposure to ambulatory patients. We also might have a risk for the patient population if these patients, which might be COVID positive, are traveling on a frequent basis back and forth to our hospitals. And of course, we have the risk for our patients themselves. They might be at increased risk for catching a COVID-19 infection by frequent traveling. They might have an increased risk for a severe course of SARS-CoV-2 infection by concurrent thoracic radio or radiochemotherapy. And I think we should also not forget there might be an increased risk by the cancer, in particular, if we change to a suboptimal pandemic-adapted way of cancer treatment and specifically radiation oncology. And these are risks which we need to balance and we need to be aware of. So what we've tried in this multidisciplinary, in this international practice recommendation, we tried to use a Delphi methodology, a consensus methodology, to give recommendation in this time of crisis. The aim was to rapidly provide guidance about the potential need to adapt practice and fractionation of radiotherapy for lung cancer in the current COVID-19 pandemic. The practice recommendation, they have been endorsed by ESTRA and ASTRA societies. We had 32 international experts participating, and that was all done within a very quick time interval between the 24th and the 27th of March, and we had a participation rate of minimum 91%. So at that time, I would like to thank again, in particular, David Palmer, who organized this consensus process together with me, and all participants who have dedicated their time, in particular in this time resources scare issue. So what have we done? We have prepared 6 typical lung cancer cases. Stage 1 patient who has been considered as medically inoperable, and where the standard would be for non-operable patient SBRT. Case 1, stage 3, bulky N2, where the standard would be a concurrent radiochemotherapy. And resected N2, multi-station, multi-extranodal spread, post-operative, where we could consider post-operative radiotherapy. Limited stage small cell lung cancer, where the treatment goal would be concurrent radiochemotherapy. Again, limited stage small cell lung cancer case who's had a good response to radiochemotherapy, and we consider prophylactic cranial irradiation. And we also had a palliative case who had a failure to first-line systemic therapy and developed mediastinal progression, severe cough, and moderate dyspnea. We assumed that all these patients would have average or standard characteristics of our cancer population. So the first question we asked is, would we postpone the initiation of radiotherapy if a patient would be diagnosed of COVID-19 positive before the start of treatment? Would we defer the start of treatment until the patient becomes COVID-19 negative and becomes asymptomatic? And here we saw a very strong consensus in almost all cases. We should not rush into this active infection, irrespective of the case. And the consensus was ranging between 74% and 100%. We also asked the question, what happens if the patient catches a COVID-19 infection during radiotherapy treatment? So the treatment is already ongoing, and you know that interruption of radiotherapy treatment might put the patient at increased risk for failure because of repopulation and progression of the tumor in this time interval of non-treatment. Here we saw a mixed picture. You can see that in the radical treatment for stage 1, for stage 3, and for the small cell lung cancer patient, there was kind of a 50-50, whether to interrupt or whether just to continue. Whereas in the kind of more adjuvant or elective treatments, the post-operative, PCI, and the palliative, there was a consensus to interrupt radiation, to wait until the patient becomes asymptomatic, and also if he becomes COVID-19 negative, not bearing an additional risk to healthcare co-workers and to other patients. We further asked what are factors which can support us in our decision-making process, whether to interrupt or whether to continue treatment in COVID-19 positive patients during a radical treatment for stage 3 non-small cell lung cancer and limited stage small cell lung cancer. And there were 3 factors which were identified and consented. Of course, it's the severity of COVID-19 related symptoms. If the patient is on an oxygen support, it might not be the wisest situation to continue treatment. If the patient might be nearly asymptomatic, we might be more courageous to continue treatment. The severity of lung cancer symptoms themselves, they should be considered as well. And of course, also whether we are right at the beginning of treatment or already at the end of the treatment course. Another question is, if the patient has just been consented, he has been in the multidisciplinary tumor board, we have made an indication for radiation, and now we're in this pandemic phase. Should we just wait? I mean, currently we are seeing that the pandemic is kind of decreasing. Why not wait for another 4 or 6 weeks until the pandemic becomes less severe? The risk for the patient, for our healthcare co-workers might decrease. So should we postpone the initiation of treatment? And again, we saw a very mixed picture adjusted to the different stage, to the different indication for treatment. For stage 1, there was a mixed picture. For the 2 radical treatments and for the palliative treatment, there was a very strong consensus of not postponing the treatment. Whereas in the post-operative and the prophylactic cranial irradiation, there was a consensus or even strong consensus to wait for 4 to 6 weeks. Most likely, I will address that later, because the added benefit by radiation is smaller in these 2 entities compared to the other 3. We asked the question, when would you recommend postponing this SBRT in the stage 1 case, the medical inoperable case? The factors which should be included in the decision-making process here are the growth rate. If the tumor would have a very slow growth rate, well, then it should be safe to postpone the initiation of treatment. Other factors which found some support was patient preference, solid component versus purely ground glass opacity, patient performance status, tumor size T1 versus T2, and the current and expected status of the pandemic. Another very important question which affects us as radiation oncology is, how do we deliver our treatment? The fractionation. You know, you can divide up the amount of radiation we have to deliver in a smaller number of fractions. That's what it's called hypofractionation. We have found for most tumor entities a kind of an optimal fractionation where we have the optimal anti-cancer activity, but also having the least likelihood of side effects of toxicity by radiation. And should we kind of depart from this optimal fractionation schedule? In this early phase of the pandemic, we have seen a consensus or even strong consensus not doing so in the post-operative, in the limited stage small cell lung cancer, and in the PCI case. There was some support for a more severe hypofractionation for the stage 1 and for stage 3 non-small cell lung cancer. The only case where there was a consensus to perform hypofractionation beyond currently adapted guidelines was in the palliative case, and there it was felt easily possible to go to the 5, 2, or even 1 fraction regimen. For multimodality treatment of stage 3, we also asked the question, well, should we depart from our current standard of care of concurrent radiochemotherapy followed by durvalumab? There was a strong consensus to continue considering concurrent radiochemotherapy as a standard of care and against a sequential approach, most likely because it's less effective, but also because it prolongs the total treatment time. It will cost more visits of the patient, so that was not supported. We also asked the question, would you change your treatment strategy depending on the EGFR, ALK, or PD-L1 status of the patient? That was not the case. And we also addressed the question, are there any chemotherapy regimens which are in particular kind of risky for the patient, where you see an increased risk? And there was some concern for carboplatin paclitaxel because of a potentially increased risk for pneumonitis and myelosuppression, but that was just some support and no consensus. Then we moved on. Now we're moving to the second phase of the pandemic, the late phase where we're truly having, for example, not sufficient staffing to maintain all our treatments, where the maintenance of our machines might break down. So we have to distribute our resources, we have to triage and prioritize. And there we again asked the question, would you consider further hyperfractionation in this later phase, in this more severe phase of the COVID pandemic? And here we truly observed that further hyperfractionation was recommended. Going to a single fraction approach for stage 1, going to 20 fractions for the stage 3 non-small cell lung cancer. In the post-operative and the PCI case, there was no consensus for hyperfractionation. In limited stage small cell, you could even go down to 15 fractions, and in palliative cases for 1. We also addressed the question, could you consider regular CMRI follow-up instead of PCI in early stage small cell lung cancer? And that found consensus, and even strong consensus was 83%. How do you prioritize a patient? We asked 2 different questions. First of all, participants were asked to put the lung cancer cases in order of priority, just looking at lung cancer cases. And that is seen on the left side. So the highest priority was seen for stage 3, and the second highest priority for the limited stage small cell, and number 3 was stage 1. So the radical treatments where you have a curative approach by radiation. Then the palliative was interesting. There we saw a very mixed picture. Some have put that with a very high priority because with just one single fraction, you can improve quality of life of patients. Other participants said, well, it's palliative only and not a curative scenario that should have low priority. So no consensus there. Post-operative and PCI was considered as low priority. And then we also asked the question, how would you assess the priority compared to all other cancer patients in your radiation oncology department? The radical treatments for stage 3 and limited stage, they were considered as very high priority or average for stage 1. Again, for palliative, no consensus, and low to very low priority for post-operative radiotherapy and PCI. We asked what are factors which can be used to prioritize patients. That was an open question in the beginning, and then a prioritization. And the first factor which was considered as most relevant to guide the decision how to prioritize the patient was potential for cure. The second was the relative benefit of radiation versus any other treatment, active COVID-19 infection or absence thereof, life expectancy, and performance status. What was considered as very low priority was comorbidities and age. So it's mostly the effect of the treatment which was considered as having high priority, not the patient characteristics in terms of age and comorbidities. Surprisingly, the potential impact on quality of life also had a rather low priority in this question. So I would like to conclude. We first of all should not forget, we are not only talking about the pandemic, we're talking about the pandemic mostly, not only the COVID-19 infection. Hopefully at some point of time, we will have an immunity, maybe by a vaccination or by whatever mechanism, and then we will not have to care too much anymore. But in this situation of a pandemic, we have to mitigate the risk of spread, and that from a radiation oncology perspective should be not to compromise the prognosis of lung cancer patients by departing from guideline recommended practice, because by staying to that practice, we can maintain the chance of cure or to improve cancer treatment without putting an additional risk in this pandemic. The second is, in general, there was a recommendation to postpone or interrupt radiation in COVID-19 positive patients. In the later and severe pandemic scenario, we were able to identify factors which are important to help us triage our patients' most relevant potential for cure, relative benefit of the treatment modality, life expectancy, and performance status. Thank you very much, and we hope that we are on a good path in the pandemic, and I'm looking forward to the discussion afterwards. Thank you, Jan.
So thank you, Matthias, for this very comprehensive talk and the effort for putting together all this information from all the different colleagues. I have a more practical question. Would you be afraid of irradiating a region of the lung that has been sick by COVID-19 pneumonitis? Would you avoid that? Would you replan that?
There's a nice expression what you can use as a radiation oncologist. The dose have to come from somewhere and has to go somewhere, meaning if you avoid region which you think are at an increased risk, the dose will go through any other region. So potentially steering the dose through regions which are being considered as kind of affected or being healthy, we don't know that yet. I would make it more depending on the general health status of the patient. So if the patient would be asymptomatic, I would not concerning radiations to put the radiations through this area, as we've done. So for example, if a patient had a bacterial pneumonia before, we would not spare this region more intensively.
Okay, that's very clear. So we turn now to the third speaker, and this is my colleague here in Antwerp, Dr. Joris Quin, who is a thoracic oncologist at the Antwerp University Hospital, and who will discuss the issue of systemic therapy in the time of COVID-19. Jo, it's up to you.
Thank you, Jan. Okay. These were my conflicts of interest. This has already been explained by Isabel, but what is important is that of all solid tumors, lung cancer patients are most at risk for COVID-19 complications, with a very high mortality in the New York population. And this is due to the advanced age of lung cancer patients and due to the comorbidities they suffer from, most importantly, COPD. What is also interesting from the New York population is that more than half of these patients had been in contact with healthcare less than a month before they got ill. So in fact, we make our patients ill. So what do we have to do? We have to limit contact of our patients with healthcare by selecting oral therapy over intravenous, by allowing treatment at home instead of in the hospital, by preferring outpatient over inpatient, by increasing the intervals between treatments, and maybe even by not treating them. The British Thoracic Society recommendations offer some guidance for our praxis, but take a more restrictive stand. ESMO prioritizes treatments from high to low, and I've tried to integrate this into my presentation. Another objective is to reduce neutropenia because it's a well-known risk factor for complications. Whenever possible, you should apply video or telephone consultations, especially to discuss results or to follow up on symptoms you already knew about. You can have blood drawn at home to avoid queuing in hospital, and you can allow patients to report on symptoms by their mobile phone in order to decide whether a treatment should go on or not. I have one challenging question for you. A 74-year-old male patient is diagnosed with small cell lung cancer, and he's scheduled for his, that is too early, but he was scheduled for his second chemotherapy. One day in advance, he's screened for COVID-19 and he tests positive. So what are we going to do? Are we going to continue chemotherapy because he is asymptomatic? Do we request a chest CT to exclude pneumonitis? Do we postpone chemotherapy 1 week to see if he becomes ill? Or should we postpone everything right away for 4 weeks? You can now vote. So in fact, there is no right answer because there is no evidence. There's only expert opinion. There is consensus that we should not give chemotherapy to patients with an active COVID-19 infection, but we are unsure what to do with patients who test positive but have no symptoms. TKIs are usually not a problem, and immunotherapy is somewhat controversial because it could exacerbate pneumonitis, and maybe it could induce the so-called cytokine storm, which is a feared complication of COVID-19. At the other hand, immunotherapy could also restore the immunodepression caused by cancer. If your patient has had COVID-19 and you want to restart treatment, then you have at least to wait until all symptoms have disappeared. But some experts also advise to retest these patients, although viral RNA can persist for a long time, so this remains controversial. If we then go to first-line chemotherapy for stage 4 small cell lung cancer, this is high priority according to ESMO, then we would recommend to give classical chemotherapy 4 cycles and to omit immunotherapy because the small gain in overall survival does not outweigh the need for maintenance therapy, especially now that the latest trial with pembrolizumab in this setting was negative. Oral etoposide gives you the possibility to reduce time in hospital, but is probably inferior to IV etoposide, but it is not necessarily an issue in the palliative setting. Second-line chemotherapy should be oral topotecan and is of high priority in patients who are symptomatic. Third-line treatment should be considered only in fit patients with low risk who request treatment. Next slide. Yeah, so if you resect a small cell lung cancer, then you should give adjuvant chemotherapy. But in elderly patients and patients who are not very fit, you should discuss omitting it. In the curative setting, I would not use oral etoposide because I think it's a suboptimal treatment. Adjuvant chemotherapy for non-small cell lung cancer gives you an overall survival gain of about 5% and is high priority in young patients who are fit and have a greater risk of relapsing due to more advanced disease. In stage 1B, it's controversial and it could be omitted during the COVID pandemic. In elderly patients, patients who are less fit, you might discuss omitting it or maybe stopping early. The optimal regimen in non-squamous histology is cisplatin plus pemetrexed. In squamous, we would advise cisplatin plus docetaxel to avoid the day 8 of vinorelbine and gemcitabine, although vinorelbine can be given orally. In patients with an EGFR mutation, an EGFR TKI might be a reasonable option. For non-squamous histology, we would recommend cisplatin plus pemetrexed as the chemo regimen in the chemoradiation. If you give consolidation durvalumab, you can increase the interval by doubling the dose, which is safe. If you are treating a patient with a TKI and everything goes well, you should keep the patient at home and increase the interval of follow-up visits. If such a patient has progressive disease, it is not always necessary to switch to the next line. You could consider to continue the TKI beyond progression, sometimes for months. And we would not give bevacizumab or ramucirumab in this setting. If there is no driver, usually we give chemotherapy plus immunotherapy or immunotherapy alone, and the latter is preferred in patients with high PD-L1. It is also possible to double the dose of pembrolizumab and to double the interval. If a patient has toxicity and no signs of progression, you should not lightly restart immunotherapy. And if you want to treat very old patients or patients who are not very fit, you should tread lightly and carefully. Pemetrexed maintenance therapy often becomes a burden after a while, so I would stop early. And if the patient has no symptoms, you could wait and just observe. In second line, we prefer immunotherapy if it has not already been given. You can equally double the dose of nivolumab. And if you give docetaxel, we prefer tri-weekly administration over weekly regimens. Third line chemotherapy, again, is reserved for patients who request treatment and are very fit. The standard of care for mesothelioma is pemetrexed-based chemotherapy, and we would not give these patients bevacizumab. Pemetrexed maintenance is not indicated in this setting. There is no well-established second-line treatment, but we would prefer immunotherapy if available. For thymoma and thymic carcinoma, our preferred regimen is cisplatin plus etoposide. And in second line, we would advise pemetrexed given its good toxicity profile. If the patient has bone metastasis, you could have him administer denosumab at home. And I wouldn't send them to the dentist if you can get an appointment anyway. To prevent transfusions, I would advise dose reduction or early discontinuation of chemotherapy in palliative setting. To avoid blood transfusions, you can also give IV iron and maybe EPO, although this is controversial. If the patient can't be cured, you should discuss advanced care planning, and there should be a DNR order in the medical file, which should also have been the case before the COVID pandemic. We do not recommend routine use of G-CSF in all patients. According to the guidelines, it is reserved for patients at high risk of febrile neutropenia. we could be somewhat more lenient in the COVID era, but by expanding it to the patients with intermediate risk, but it's not a good idea to give it to all patients because potentially it could worsen the pneumonitis. This is my last slide. There are some limitations to these recommendations. Local reimbursement criteria may not allow other treatments or other ways of follow-up. Some drugs might not be available in your country, for instance, oral vinorelbine. And if you have no experience with a certain drug, I would not give it because usually you get into trouble.
Okay, I think you're done, Jo?
Yes, I'm done. I'm done.
Okay, thank you very much. And we have a couple of minutes for questions. Can you just briefly comment on, have you seen any interaction between some of the COVID drugs and the drugs that are given systemic therapy or immunotherapy? Has there been any concern about that?
Well, the short answer is there are no COVID drugs. If you mean hydroxychloroquine, well, it has two side effects of concern. It causes a prolongation of the QT interval, which might be a problem with some TKIs or with some supportive drugs like antiemetics. And it could also cause bone marrow suppression. But we have not seen any problems, but we would not treat these patients except for TKIs during their active infection.
Hello.
Yes, Jan?
So you have some of the antiviral drugs in trial.
Yes, but this is only in trial.
Yeah.
We have had some patients who have had antiviral drugs, but we have seen no severe adverse events. No.
I guess those patients will not be accepted in the clinical trials if they have a systemic therapy.
No.
Jan, do you see two questions on the question and answer feature? Or shall I read them to you?
Hello. Yeah,
Hello?
Matthias? Yeah, Matthias? Is Matthias there?
Yes, here.
I have one question. There is a question in the box. Do you routinely screen for for COVID prior to the start of radiotherapy?
That's a very good question. So what we are currently doing, and I wouldn't say that this is evidence-based, but we're currently screening all patients who are admitted to our patient in-ward. So they are being swabbed, having a PCR test before they're admitted to hospital. How do we handle the ambulatory patients? There we have implemented a 4-week screening interval, even in asymptomatic patients. So we screen them once at the beginning of radiation and once in between. If you ask us, why do you do it on a 4-week scale and not on a 2 weeks or weekly or daily? Well, we have to balance the risk of the procedure of the test itself. And that was a discussion we have had with our infectiologists and what we have been also kind of being able to implement from a resource perspective. So we do some screening, but we're very much aware that the patient could catch a COVID-19 infection the very first day after he has been tested negative. That's a risk we have to take. And that again reminds us how serious we have to take the hygienic measures at the machine at our RTTs level. So,
and what are the precautions in the COVID-19 positive patient? Do you treat them the last of the day, or you have a separate linear accelerator for him?
Interestingly enough, we have not had a patient yet. We expected that very much early on, but so far we have not. What we've prepared is we have decided we would have one COVID linear accelerator accelerator where the patients would be pooled at the very end, where they would be in an empty waiting room. So we would not want to mix them with non-COVID infected patients. And we would only be having them treated by RTTs who would volunteer to treat these patients. That would have been the measures if we would have to treat them. And I guess we will come into this situation at some point of time.
Thank you. There are there's a question for Dr. Raskin and Dr. Opitz, and it is the following: during the most intense period of pandemia, when surgery is not possible, would you rather change adjuvant therapy for neoadjuvant therapy to delay the surgery, but still give treatment in a patient that, for instance, you know will have anyhow adjuvant treatment? Let's say a T4N0 tumor. So is this a way of avoiding a treatment pose by switching from adjuvant to neoadjuvant?
So
Isabel?
consider chemotherapy safer than surgery. If surgery is not possible, then it could be a rational option to start with chemotherapy. But of course, chemotherapy is not without risk. It's something you have to discuss with your multidisciplinary tumor boards, with your surgeon and your oncologist together, I think.
Okay, and
yeah,
Isabel?
I would I would also say, obviously, you can delay the surgical intervention by applying an induction concept. On the other hand, you're weakening the patient further by an upfront treatment. And if this is already an older and patient with comorbidities, you're putting him even more risk for the later surgery if you switch to a neoadjuvant concept. So I would be in favor of doing the surgery first.
Okay. Then a question for you. Do you routinely screen patients for ambulatory chemotherapy, and how often? So what are the measures regarding that?
Well, if a patient has to be hospitalized for chemotherapy, they have to be screened. We screen every patient that is hospitalized. In the day clinic, upon their first administration, they are also screened.
Okay, then there's a question: have you seen many patients with lung cancer COVID-19 positive? I can just answer for my institution. I think we've had 4 or 5 now. If you look at that TerraVolt survey, which was mentioned by Isabel, there are now for the moment already 450 and nearly 500 patients in that survey. So, and that was over a month or 6 weeks. So it's I think the number of patients is quite impressive. I don't know, Isabel, have you seen many COVID positive patients?
So I've not seen a single COVID positive lung cancer patient. We've seen other patients, but not lung cancer patients.
Have you seen any operated patients getting COVID-19 in the nosocomial setting?
We have operated on a patient, but it was not for lung cancer. He had a pneumothorax as a consequence of his COVID-19 infection, but he was not a cancer patient. And other ones we've not been operating on.
So we've had a couple of cases of nosocomial COVID-19 infection in patients hospitalized for another reason, lung cancer patients who developed COVID-19 during the course of their illness. Some of them had a quite severe course, some of them are quite an indolent course. So it's not very clear. So I have a last question also regarding the use of bronchoscopy. Since bronchoscopy increases the risk of disease transmission, would you consider alternative diagnosis like sputum antibody, antigen testing, etc.? Is this something for you, Isabel?
So in a patient being having a proven COVID-19 infection or a high risk of it, I was mentioning earlier that we are considering non-invasive staging being imaging methods. But for other patients who are negative, and as we are all testing all patients, we would still perform invasive diagnostic procedures being bronchoscopy or EBUS for mediastinal staging in our current setting.
Yeah. So I agree with
what
that.
I can, yeah, and we have particular protection measures for the staff being exposed to the airways in this situation.
I can agree with that. It's also the policy here in my institution. You could theoretically consider turning to CT scan puncture, but the problem is that the CT scan is nowadays overloaded because they have to do CT scans for COVID-19. So the problem is displaced. So having said that, it's 8 minutes past 7, so a little bit over time. We've addressed all the questions that were put through the screen. So let me thank the 96 participants for their patience and their attendance. Also, especially the 3 speakers, so Jo, Isabel, and Matthias, for their commitment and the fact that they had to submit very rapidly their slides. And last but not least, the ERS for this opportunity to show that the ERS is also actively involved in the management of lung cancer and has a predominant role in the pulmonological sphere in that. So thank you very much, and have a nice evening. And I hope to see or hear you at one of our next webinars or during the virtual annual ERS meeting, which will be held in the beginning of September. Have a nice evening, and thank you very much. Bye-bye.
Thank you, Jan, also for your moderation, and have a nice evening, everybody.
Thank you.
Thank you very much. Have a good evening, everyone. Take care. Stay healthy.
Thank you.
Bye.
Bye-bye.
Bye.
Bye.